IV fluids. In your books, there's not a lot of pages on IV fluids. However, there's a lot of information in those few pages. IV fluids are often used in patients that are hospitalized. They're used to correct fluid and electrolyte imbalances, and they're used for hydration. If there is a fluid loss or the patient's unable to take in adequate fluid, they'll become dehydrated. If a patient's dehydrated and it's not corrected, it can lead to renal failure. We want to correct those fluid imbalances as soon as possible. The amount and the type of IV fluids will depend on the reason for the hydration. Maintenance therapy is used when a patient is unable to take an adequate amount of fluid, or they're having surgery and they are in PO. Fluid loss or hypovolemia. This patient could be a patient that was in an accident or has had bleeding for some reason, or a patient with fluid loss has an NG tube, diarrhea, or vomiting. An IV can also be needed for a patient who needs medications that are only available by IV. A few things to know. Never give sterile water IV push. It's used as a diluent for reconstitution of medications, but sterile water can cause hemolysis of the cells, so we use it on a very limited basis. A maintenance therapy is usually 63 to 83 mLs per hour. Replacement of fluids, usually the rate is 83 to 125 mLs per hour. Hydration ranges usually 60 to 120 mLs per hour. If a patient's NPO, the IV is usually 125 mLs per hour, and often potassium is used. If they are moderately or severely dehydrated, the rate is around 150 mLs per hour. If the patient is a cardiac patient and fluid overload, if the patient has a cardiac disorder, there's a risk for fluid overload, so they may want to run the IV fluids at 10 to 15 mLs per hour. This is just to keep the vein open and keep IV access. If the patient has a fluid volume deficit, they're likely to continue the IV fluids at 200 mLs per hour. If you're trying to hydrate someone, anything less than 125 mLs per hour is not appropriate. Isotonic solutions. Isotonic solutions contain the same osmolality as extracellular fluid. This will expand the ACF. We use it to expand electrolytes. The osmotic pressure within the cell is the same as the outside of the cell. We would not use isotonic solutions with heart failure patients or patients with hypertension. We'd want to monitor them for fluid overload. The best way to evaluate fluid overload is by listening to their lungs and checking for jugular vein distension. You'll also want to watch for edema in the lower extremities and the fingers and the hands. 0.9% sodium chloride contains sodium and chloride. It is used for hydrating patients and is useful for patients in hypovolemic shock. We use it for blood transfusions. It's the only fluid that we run blood transfusions with. We also can use it for fluid challenges. When we're giving a patient a fluid challenge, the physician usually also gives them Lasix. A patient with low blood pressure during resuscitation, if a patient has metabolic alkalosis, hypercalcemia, or even fluid replacement in a patient with DKA. Do not use normal saline for a patient with cardiac failure, renal failure, or hypernatremia. Lactated ringers contains sodium, potassium, calcium, chloride, and does not contain magnesium. It resembles the normal electrolyte composition of blood and serum plasma. The amount of potassium will not meet the daily requirements. It does contain lactate, which is the precursor for bicarbonate. Do not use this in patients that are alkalotic or if they're in liver failure. It will cause lactic acidosis in liver failure patients, and it also gives them extra potassium. Lactated ringers is contraindicated with patients with hyperkalemia. Uses. We use it for dehydration, burn victims, lower GI fluid loss, so if there's an NG tube in place and it's to suction, acute loss of blood if not giving 0.9 sodium chloride, hypovolemia due to third spacing, mild metabolic acidosis, and a salicylate overdose. This is the IV fluids that we give to all of our labor and delivery patients, and we also use it preoperatively and post and intraoperatively. Other isotonic solutions are D2.5 and 0.45 sodium chloride. These are helpful in establishing renal function. D5.2 sodium chloride is daily maintenance of body fluids when less sodium and chloride are necessary. Hypertonic solutions. They contain a higher osmolality than ECF. It provides less water than electrolytes and increases the ECF osmolality. It pulls the fluid from the intracellular fluid. The cells shrink, the extracellular space expands, and you're going to need to monitor them for circulatory overload. Do not use this in diabetic ketoacidosis, and don't use it for impaired kidney and renal functioning.